Hello guys, hope you are all okay. You are all enjoying. I am Dr. Arshad Awan with my ultrasound and radiology teaching videos. The topic of discussion today is related to musculoskeletal abnormalities, and the joint which I have picked is a very common joint, and most of the time you will see that the people will complain of the knee joint secondary to the effusion. Effusion can be like simple effusion or complex effusion, maybe primary or maybe secondary. There may be hemorrhage secondary to trauma or gout or inflammation. So there are multiple pathological processes which I have discussed in the coming slides, so you have to just focus on that. As far as the knee compartments are concerned, there is superior compartment, suprapatellar recess, there is medial compartments, and beside this you can also have, you can see the posterior compartment where the Baker cyst is quite common. I have also focused on the hypertrophic abnormalities, the problem related to the deposition or gout or rheumatoid arthritis, or there is some possibilities of lipohemoarthritis, intra-articular fracture, or chordoma, certain sort of a echogenic tumor which usually involves the knee joint or knee compartment. All these points and features has been discussed in detail. You just watch this video and I'm sure you will be able to pick the joint effusion so far its diagnoses are concerned. And beside this, I have also focused on how to write the report, and how you will shape your diagnosis and what would be the next modality. So let's start watching this video.
Etiology of the joint effusion, especially knee joint effusion, can be classified into two. It could be inflammatory and it could be infective. If we talk about the pathology of the knee joint effusion, it could be exudative or it may be transudative, and it may contain pus, it may contain blood, there may be fat components in it, and this may be caused by trauma. Sometimes this joint effusion may be caused by deliberate injection because of contrast medium, or sometimes it will also be considered as an iatrogenic effusion when you introduce some medication in it and it results into effusion. Joint effusion could be because of lipohemarthrosis. In this condition, there will be intra-articular fracture, and because of intra-articular fracture, the fat marrow will leak into the joint compartment and you will be able to see fat fluid level within the joint. On this ultrasound imaging, you can appreciate moderate fluid collection in the supraquadriceps recess. You can appreciate low level echo. You can also appreciate fat globules within it. If you concentrate on, you will be able to see low level internal echoes. As far as quadriceps tendon is concerned, myotendinous junction, it's okay. So far the attachment point is concerned, there is no tear in it. So this is a classical example of supraquadriceps recess effusion, and there is a variety of differentials you can write on the report. It could be because of infection, it may be because of lipohemarthrosis, and it may be also because of lipoma arborescens. So you need to have the patient investigations and history with you. You must comment on the supraquadriceps tendon, you must comment on the myotendinous junction. While writing the report, your ultrasound report should have all these information. You have to write down where the fluid is and which compartment this fluid can be seen, what the contents of the fluid is, whether there is any pus or whether there is blood or there is any fluid level. Beside this, also comment on the ligament status, on the cartilage status, if there is any loose body floating within the effusion, within the fluid, and at the end you must give your differential diagnosis. First of all, try to write down the exact diagnosis if you are sure, and if you are not, so just give them 3 differentials. and after that you must also advise what next, whether there is any aspirations requested or if there is any MRI scan required. So whatever you think, so your report should have all these information for the ease of the clinicians.